So today's lecture will be about three important viruses, the rhinoviruses, the coronaviruses, and the adenoviruses. The expected learning outcomes for the first part of this lecture about rhinoviruses include the knowledge of the basic structure of rhinovirus, the scope of its clinical presentations, how it is transmitted, and how it can be prevented, including how we develop immunity to it, the complications that might occur as a result of infection, and the limitations of treatment. First, the rhinoviruses, which used to be a separate genus of Coronaviridae, and now are included among the enteroviruses. They are very small RNA viruses. They come in more than 160 types with three major species, the A, B, and C, and they account for the majority of what we encounter as common colds that we get once or twice every year. The rhinovirus capsid has four proteins. They are named viral proteins 1 through 4, three of which are major and one is a minor protein. And they differ between one species and the other. And the differences dictate which cellular receptors they bind to. So rhinoviruses A and B bind to the intercellular adhesion molecule 1, ICAM1, which is found on respiratory epithelial cells, whereas rhinovirus C binds to the cadherin-related family member 3 and thus can cause infection in the respiratory tract as well. After the virus enters the cell, the innate immune system, of course, responds to the attempts of the virus to replicate, but usually this is a failed attempt and the virus continues to make more virus and to replicate and then cause cell lysis and release of the virus from the inside of the cell. The preferred replication temperature for rhinovirus, as with other cold viruses such as the coronaviruses, is about 32 degrees, and this temperature is usually that of the nose and the upper airway. So this is why they tend to occur a little bit more in the cold seasons. So the clinical presentation of rhinoviral infection is mostly that of the common cold. Infection usually is quite rapid once the virus is acquired from an infected individual. Within about 15 minutes, the virus enters the cell and starts replicating. The incubation period until symptoms appear is dependent on the size of the inoculum and several host factors that dictate the immune response. But that can range anywhere from 20 hours to 4.5 days. The symptoms of the common cold are quite familiar: runny nose, congestion, sneezing, a slight sore throat, a mild cough, and some malaise and headache. Towards the end of a rhinoviral infection, the secretions from the nose may become thick and yellow and sometimes a little bit purulent, and those usually last 2 to 3 days and then resolve spontaneously. The symptoms last about 1 week, sometimes up to 2 weeks, and fever is unusual except in young infants who are susceptible to more severe forms of the infection with rhinoviruses. Transmission of rhinovirus is similar to other respiratory viruses. It's usually via aerosols that may contaminate surfaces, and then the virus gets picked up by another individual. So if somebody has a rhinovirus infection, they could sneeze. If they don't cover their mouth when sneezing, the droplets will land on surfaces around them, and those surfaces become contaminated and a place where other people may pick up the virus and inoculate themselves. Children are very good at doing that because they don't practice hygiene quite well. They don't cover their mouth when they cough or sneeze, so they end up contaminating other children, particularly in the setting or in the preschool. Immunity is usually antibody based, so antibodies against specific serotypes of rhinovirus are usually protective. So we usually build up immunity as we grow older. But when we become very old, the elderly become at risk of starting to get recurrent rhinovirus infections. Incidence usually is highest in the cold months between between the early fall and mid-spring. So in our part of the world, it's between September and April. But we see rhinovirus infections throughout the year, although they become less frequent in the summer months. So most rhinovirus infections are uncomplicated and self-limited, but sometimes they get complicated, particularly in people with underlying risk factors such as allergies or immune deficiency. These complications include bacterial sinusitis or bacterial otitis media. Sometimes in young infants, rhinovirus may cause a primary viral pneumonia that can be quite severe. And in asthmatics, whether children or adults, rhinovirus infection may cause an asthma attack. The immune response to rhinovirus is usually antibody mediated. Antibodies can protect in a serotype specific manner against future rhinovirus infection. And because there are so many different rhinoviruses, there is a learning curve with age, so that as children grow up, their immune system recognizes more and more types of rhinovirus, and infections become less frequent. But in the elderly, as their immune system undergoes senescence, they become susceptible again and they become infected with rhinovirus repeatedly. Prevention of rhinoviruses is usually by hygiene. There is no vaccine available against rhinoviruses. So to try to prevent it, we need to practice good hand hygiene. So the virus survives for about 3 hours outside the human body. And if we touch surfaces that are contaminated, washing our hands with soap and water would be sufficient to remove the virus and prevent inoculating ourselves in the nose or the eyes or in the mouth and getting sick from rhinovirus. As for the treatment of rhinoviruses, there is no specific treatment for rhinovirus infection that is available. Most bodies that issue guidelines for treatment, including the CDC, the American Academy of Pediatrics, and the American Academy of Family Practitioners, they advise no treatment for rhinovirus infections. Specifically, they point out there is no room for antibiotics even when there is mucopurulent rhinitis. As I mentioned, this occurs in the last 2 to 3 days of infection. But unfortunately, the actual practice is that for the common cold, many people and many physicians, unfortunately, get treated with various preparations, including antibiotics, various cold preparations that include antihistamines, decongestants, mucolytics, vitamin C, zinc, herbal preparations, etc. All of these have been studied, and none of them has been shown to improve or affect positively rhinoviral infections or the common colds in general. So they are really a waste of time and money. In fact, in 2008, the FDA prohibited the use of cold preparations in children under the age of 2 years because of serious side effects that led to the death of several infants who were being treated particularly by combinations of antihistamines and decongestants. So, based on the above, rhinoviruses are RNA viruses that are among the most prevalent causes of the common cold. Infections can occur throughout the year but are more common in the fall and winter months. The virus is transmitted via aerosols and contaminated surfaces, such as the hands, so prevention is by wearing masks and washing hands frequently. In some settings, such as young infants and children, infection can be complicated by secondary infections such as otitis media or pneumonia and can cause asthma exacerbations. No specific treatment is available. The expected learning outcomes for the second part of this lecture about coronaviruses include the appreciation of the structure of coronaviruses and the relative abundance of human versus animal coronaviruses, to understand the basics of the replication cycle and the role of mutations in viral evolution and development of viral variants. Also, to understand how the virus manipulates the immune response and how it is transmitted and how it can be prevented, including through host immunity and vaccination. Also, to understand the scope of clinical presentations, including that of severe acute respiratory syndrome, and to appreciate the short and long-term complications following infection and how treatments may modify outcomes. Next, we'll talk about the coronaviruses. This is a hot topic now because they are responsible for why I am giving you this lecture on Moodle rather than in the classroom in a face-to-face meeting. So these coronaviruses are actually quite common. They get their name from having this halo or corona that is visible on the electron microscope of the virion. These are the largest RNA viruses that we know of. They come as a positive stranded RNA ready for translation as soon as they enter the cell and make it to the ribosome. They have a complex envelope structure with several capsid proteins. The most important one that we will need to discuss is the spike protein, the S protein. This is the one that is butting out of the virion, giving it these spikes that look like the halo that we talked about. Now, similar to influenza viruses, these viruses are undergoing continuous mutation in their capsid protein genes, so they continuously change their antigenic determinants in the capsid. So there are 7 known human coronaviruses. The first 4 on the slide are quite common coronaviruses that cause the common cold across age groups, although more prevalent in children usually. Infants and young children who go to daycare as well as school children, and they do also infect adults. And the 5th known human coronavirus was identified about 20 years ago when there was a small pandemic causing severe acute respiratory syndrome, and the virus was named accordingly, the severe acute respiratory syndrome coronavirus, or SARS-CoV. The 6th coronavirus that caused infection in humans
was the Middle East Respiratory Syndrome coronavirus, which was identified about 10 years ago and is still causing infections in the area of the Arabian Gulf region. And then the seventh human coronavirus is responsible for our current pandemic, the SARS-CoV-2, which causes the coronavirus infectious disease 19 because it was identified in the year 2019.
So when you look at the family tree of coronaviruses, you'll find that the previous four human coronaviruses that we were quite familiar with came from two major branches of this family. Two of them came from the genus Alpha coronavirus, and two of them came from the Beta coronavirus genus, but from the A lineage. When SARS-CoV virus was discovered about 18 years ago, it was found to be from a new branch, the B lineage of the beta coronaviruses. And when MERS-CoV was discovered, it came also from a new branch from the C lineage of beta coronaviruses. And the most recent addition, the SARS-CoV-2, comes also from the B lineage of the beta coronaviruses, as it is quite similar to the earlier SARS-CoV. Now, if you look at the family tree closely, you'll find that a lot of coronaviruses actually come from bats. That the bat seems to be their natural host. They cause a very minor infection in the bat, but highly productive, so that it can generate a lot of virus and infect other bats. And occasionally, these coronaviruses can jump into other mammals, and sometimes through intermediate hosts, they can then jump to the human. And in fact, all the coronaviruses, the human coronaviruses that we know of, originated from bats. And if you look closely at the family tree, you find that there is a lot of sequence homology with other bat viruses, and that's true for all the human coronaviruses. Now, as with other RNA viruses, once they enter the cell, the replication is quite similar. What distinguishes them from other viruses is the receptor interaction. So in the case of the SARS viruses, both the SARS-CoV-1 and 2, their preferred receptor is the ACE2 receptor, the angiotensin converting enzyme, which is present on a lot of respiratory epithelial cells, as well as in the kidney, in the brain, and in a few other organs. And the spike protein of the SARS viruses is what dictates the affinity to this receptor. And here, the mutation of the gene that encodes for the S protein in coronaviruses gradually led to an S protein that can bind with great affinity to the ACE receptor. On the other hand, the MERS-CoV virus has a different receptor. It's the dipeptidyl peptidase receptor, which is a very ubiquitous enzyme present on the cell membrane that has an important role in apoptosis and in cell regulation. It actually regulates a number of proteins that are important in glucose homeostasis. So the coronavirus, again, mutations caused the S protein to become or to develop a high affinity to this receptor and be able to infect cells that express the DPP4, which are again ubiquitous. It's present in a large variety of cell types, including bronchial, alveolar cells, the liver, the brain, the kidneys, and endothelial cells of the vasculature. So transmission of coronaviruses is usually by droplets that get aerosolized when somebody coughs or sneezes when they're infected with coronaviruses. Now, of course, coughing and sneezing etiquette, when you sneeze or cough in your elbow, they will prevent this jet that gets thrown out of the cougher's or the sneezer's mouth. Usually the range of spread after a cough or a sneeze is about 1 or 1.5 meters, depending on the strength of the of propulsion. Therefore, the droplets will land on surfaces that are around the infected individual. Of course, in young children who are in daycare settings and young ones in preschool may not practice these etiquettes well, and they will cough or sneeze in each other's face and spread the coronavirus quite easily. Now, again, the coronavirus may last for a few hours on these surfaces, and hand hygiene is important in preventing the spread if somebody touches contaminated surfaces. The clinical presentation of most coronaviruses is usually, as I mentioned, that of the common cold in humans and in most other mammals. In infants, it can be a little bit more severe, causing bronchitis or bronchiolitis and sometimes pneumonia. Gastrointestinal disease is also seen in domestic animals where outbreaks of coronavirus infection can occur. Now, the severe lower respiratory symptoms are characteristic of the more recent coronaviruses, the SARS-CoV-1 and 2, and the MERS-CoV infections, which unfortunately are frequently fatal. So let's discuss the first of these viruses that causes severe respiratory syndrome. The SARS-CoV outbreak started in 2002 in Guangdong province in China, and subsequently within about 2 months it became a pandemic. This pandemic fortunately lasted only 6 months. There were a total of 8,400 cases worldwide, with 774 deaths in 26 countries and 5 continents. Now, this outbreak illustrated the potential for air travel and globalization in disseminating emerging infectious diseases, as we are currently witnessing with its cousin. Now, the SARS-CoV turned out to be a bat coronavirus that had jumped to humans, and the intermediate host was figured out to be the masked palm civet after some research, which is an animal that is also prevalent in China. The clinical presentation of SARS was similar to the current outbreak. The incubation period was 2 to 14 days. Initially, it started with a flu-like illness with fever, chills, headache, myalgias, a sore throat, and sometimes diarrhea. And within about a week, deterioration occurred with a dry cough that was shortly followed by dyspnea. Chest x-rays done initially were clear, but high-resolution CT scans, when done, showed the ground glass appearance on the CT scan, indicating the presence of a pneumonia. And acute respiratory distress syndrome was a feature of the deteriorating cases who required intensive care and sometimes developed complications and died. The overall mortality rate was about 9%, and 50% of those who died were older than 50 years of age. Now, the next coronavirus we want to talk about is the MERS-CoV virus, which appeared in Saudi Arabia in 2012, although later it was estimated that it had been circulating for about a year before it was recognized. Now, this virus also originated in bats, but the intermediate host was the camel. And the sequence homology between the camel virus and the human virus was more than 99%. As I mentioned, this is a member of the C lineage of the beta coronaviruses, and has a different receptor, the DPP4 receptor. This receptor is present on many cells, including the non-ciliated epithelial cells, which is quite unique for this virus, as it can infect those cells and cause quite severe disease in several organs of the body. In addition, it has several tricks to avoid the innate immune system. So transmission of MERS-CoV is less efficient compared to the current SARS-CoV-2 virus. Most patients who got infected were in close contact with camels, or were household members of patients who were infected, or were healthcare workers who were taking care of those patients. So it's not as good at transmission as the current virus that we are and most of the cases that have been encountered were in Saudi Arabia, and there is also a small cluster in the United Arab Emirates. Most other cases that were outside these two countries were related to visits to these two countries and contact with camels or with people who were infected. Clinical presentation is very similar to that of SARS. Initially, they get flu-like illness, followed by rapid deterioration. Usually, there's a mean of 2 days between hospitalization and admission to intensive care with the ARDS. The extrapulmonary manifestations include nausea, vomiting, diarrhea, hepatitis, acute kidney injury, neuro manifestations, and leukopenia, lymphopenia, all of which are indication that this is a systemic viral infection that is not limited to the lungs. Diagnosis, as with the other coronaviruses, is by PCR. Antibody-based diagnosis is adequate for retrospective diagnosis of patients where at the time of presentation the coronavirus was not suspected. Viral culture, as with other serious coronaviruses, is risky because of the risk of spillage or contamination or aerosolization of the viral culture. Mortality in MERS-CoV was around 30%, continues to be around that. Now, because MERS-CoV outbreak is still ongoing, there is still active work on treatment and prevention. So far, there isn't anything yet as far as vaccines or specific treatment. There is an ongoing trial with the combination of the HIV drugs, lopinavir, ritonavir, both of which are HIV protease inhibitors, and the combination with interferon beta 1b. This trial is still recruiting. We don't know the preliminary results yet. Vaccines that are targeting the S protein are also under development. But steroids may be detrimental and actually might increase mortality. Similar to the current outbreak, prevention by isolation and containment is crucial in preventing the spread in the community. The next virus we're going to discuss is the SARS-CoV-2 virus, which is responsible for the recent COVID-19 pandemic. This virus first appeared in Wuhan City in China in late 2019 and then spread globally through air travel. More than 700 million cases have been documented globally, although this is a gross underestimation because many cases do not get tested, diagnosed properly, or reported. The documented number of deaths due to the COVID-19 pandemic was close to 7 million, but again, this is thought to be a gross underestimation. There is still debate on how this virus crossed from fruit bats that dwell in the caves of China to humans and whether this occurred via intermediate hosts sold at the Wuhan market, such as the pangolin, which is considered a delicacy in Southeast Asia, or whether it was due to a lab leak from the nearby Wuhan Institute of Virology, where bat coronaviruses are studied. As mentioned earlier, the spike protein of SARS-CoV-2 functions as the key by which the virus opens the cell after binding to the ACE2 receptor, so that it can enter the cell and use its machinery to replicate. We have to always remember that viruses have no hidden agenda. Their main purpose is to replicate and make more virus as efficiently as possible. And as in many RNA viruses, mistakes happen as the RNA is getting copied, leading to a fairly high rate of mutations. But more than any other virus we know of, SARS-CoV-2 is equipped with a large array of proteins that work to inhibit or delay the immune response to allow the virus sufficient time for replication. First of all, the spike protein, upon binding to the ACE2 receptor, activates the transcription factor NF-kappa B, which is critical in the transcription of several pro-inflammatory cytokines such as IL-1, IL-2, IL-6, TNF-alpha, and others. Similarly, SARS-CoV-2 also activates several Toll-like receptors which also activate NF-kappa B. This pro-inflammatory signal explains some of the early symptoms that occur with COVID-19 infection, such as the high fever, the chills, the fatigue, the body aches, etc. However, the virus also makes several proteins that block the innate immune response, especially the interferon 1 pathway. In fact, there seems to be a non-structural protein or an open reading frame protein that blocks almost every step of the interferon 1 pathway, from triggering its transcription and translation and then its receptor signaling. This is critical as the interferon 1 pathway plays a critical role in the defense against viral infections. Not only that, but several other viral non-structural proteins work to inhibit pre-mRNA splicing, mRNA translation, and protein trafficking. All of these steps are, of course, necessary to synthesize cytokines and other host defense proteins. All of these tricks by the virus have evolved to delay the mammalian immune response in order to allow it to replicate. This interplay between the infecting virus and the host immune response plays an important role in how the disease progresses. In a generic viral infection, the innate immunity responds promptly, followed by the specific adaptive immunity. However, in the average SARS-CoV-2 infection, the innate immunity is delayed and more virus is produced, increasing the viral load significantly. In severe cases of COVID-19, the innate immune response is delayed even more, and this also affects the specific T cell response, which is almost absent, at least in the early phase of the infection. This leads to a very high viral load. For SARS-CoV-2 infection, specific antibodies that are generated wane between 3 to 6 months after natural infection. There are several lines of evidence that indicate that T cells are more important in the resolution of infection. Following infection, both T and B memory cells are generated and are ready to be boosted with subsequent exposure. In general, antibodies function outside the cell to neutralize the virus before it can bind to its receptor and enter the cell, whereas T cells destroy infected cells, thus disrupting viral production. The virus has other tricks that help it to evade the immune response. The most important is its ability to continuously mutate. It was estimated that this virus develops about 2 mutations per month in the global population. Of course, not all these mutations are beneficial for the virus. Many are actually deleterious, so they are not propagated. Other mutations may have no consequences, so they may be left to propagate inconsequentially. However, some mutations will give advantages to the virus, such as being able to escape the prevailing immunity in the host or in the population by changing one or more antigenic epitopes, for example. Other mutations may allow better transmissibility or better ability to bind to the receptor or more efficient reproduction of the virus or allowing it to become latent in the host. These mutations mostly occur in otherwise normal hosts, but those hosts with compromised immune systems that do not allow them to clear the virus promptly provide the virus with a better opportunity to have a prolonged infection, giving the virus an opportunity to fine-tune its host evading or immune evading capabilities. So, since the pandemic started, mutations played an important role in the perpetuation of SARS-CoV-2 infection. There must have been some mutations early on that allowed the virus, which has adapted to bats, to jump to humans and be able to bind to the human ACE2 receptor. Since then, you can think of the virus as a work in progress, trying to improve its transmissibility and immune evasion capabilities. And we saw that through the emergence of the multiple variants of the virus, with each newer variant being an improved version of the one before it, and thus outcompeting it, then completely replacing it. Omicron is the most recent variant, but there have been multiple subvariants since it emerged, and each of these subvariants has demonstrated slightly improved transmissibility and immune evasion. And this was demonstrated by the higher rates of breakthrough infection in vaccinated individuals or previously infected individuals. So it appears that there won't be a final version of the virus and that it will continue to evolve, especially to avoid the prevalent immunity in the population. Therefore, the aim of vaccination was no longer to prevent infection totally, but to prevent severe manifestations of the infection. So there is a spectrum of clinical presentation of COVID-19 from completely asymptomatic to critically ill patients. In those with asymptomatic or mild illness, usually there's a lot of viral replication but minimal inflammatory response. In those with moderate, severe, or critical illness, there is a gradual increase in the inflammatory response. Thus, antiviral treatment is usually not needed for the mild or moderate cases unless the patient is at a high risk of progressing to a severe or critical illness. For those who progress to severe or critical illness, then anti-inflammatory therapy becomes a must to control the hyperinflammation that plays an important role in the pathogenesis of these cases. This is the timeline of COVID-19 infection and how it can be modified. At the onset of the pandemic, the incubation period ranged from 2 to 14 days. However, with the most recent variant, the incubation period shortened to 1 to 3 days due to the improvement in viral transmissibility and replication in the human host. The existence of immunity at the time of exposure and during the incubation period is extremely important in determining the outcome of the illness. Of course, existing immunity can come from multiple sources. This can be from a previous infection, even if that infection was with a coronavirus other than SARS-CoV-2, as it has been demonstrated to provide some cross-protection. Of course, immunity can also be present from vaccination or from giving immune plasma donated by people who were previously infected or from monoclonal antibodies that were developed against the virus. Most of these monoclonal antibodies, however, have become obsolete as the new variants were able to evade them completely. The onset of symptoms usually manifest with fatigue, myalgias, fever, sore throat, cough, anorexia, and sometimes diarrhea, particularly in children. These symptoms will go on for a few days or a week, and in mild or moderate cases will resolve spontaneously. Antivirals such as remdesivir or Paxlovid or pegylated interferon are most effective when given during this period. The earlier the better, to prevent viral replication and further damage. In those with more severe cases, dyspnea develops, usually in the second week of the infection, as the host immunity kicks in with hyperinflammation necessitating the use of high-dose anti-inflammatory steroids. And about 14% of the patients end up with severe illness and 5% go to critical illness requiring intensive care and anti-cytokine treatment. Severe COVID-19 is characterized by a wide spectrum of manifestations as a result of the hyperinflammation that occurs, including dyspnea and hypoxemia due to the severe lung injury, progressing in some cases to acute respiratory distress syndrome. There is also a drop in the lymphocyte and platelet counts with severe elevations of inflammatory markers such as ferritin, CRP, and interleukin-6. Severe cases also suffer from thromboembolic complications due to microvascular injury, along with central and peripheral nervous system manifestations. Other organs can also be affected, including the heart, liver, and kidneys. And in some patients, shock develops and disseminated intravascular coagulation, leading to death. Early in the pandemic, 19% of those who acquired the infection got severe disease, with 5% becoming critically ill, with almost half of them dying. With the most recent variants, these numbers have dropped significantly as the manifestations of the viral infection became milder and the immunity in the population and in an individual has become stronger. Several risk factors have been identified for the development of severe COVID-19. These include older age, chronic obstructive pulmonary disease or COPD, cardiovascular disease, especially heart failure and coronary artery disease, type 2 diabetes mellitus, obesity with a BMI greater than or equal to 30, sickle cell disease, chronic kidney disease, and cancer or being immune compromised. Most interestingly, it was discovered that some individuals who seemed to be otherwise healthy yet developed severe COVID-19 had inborn errors of innate immunity, particularly relating to the interferon 1 pathway. Additionally, about 5 to 10% of patients with severe disease were found to have autoantibodies against type 1 interferon. These autoantibodies are more common in older males. The proposed mechanism for severe COVID-19 is thought to be what is called a cytokine storm. This is a state of immune dysregulation in response to various insults, including infection. It was initially described in the setting of chimeric antigen receptor T-cell therapy used in the treatment of cancer, but it's thought to have played a role in the high lethality of the 1918 to 1919 influenza pandemic and in previous plagues caused by Yersinia pestis. This immune dysregulation is probably triggered in the setting of SARS-CoV-2 by the high load of the virus through the expression of its various immune-evading proteins leading to the cytokine storm. This manifests as sustained hyperinflammation with elevated levels of cytokines such as interferon gamma, interleukin 1 beta, interleukin 6, interleukin 17, and TNF alpha, as well as activated immune cells. The clinical features that result from this cytokine storm are listed in the figure and are due to the collateral damage that occurs from the hyperinflammation. These clinical findings overlap significantly with severe COVID-19. In a fraction of patients who seemed to recover from acute COVID-19 infection, some of the symptoms seem to persist with variable intensity for a prolonged period of time. This seemed to occur irrespective of the initial severity of the disease. Moreover, a wide variety of new symptoms seemed to appear after the acute symptoms had resolved. This occurred in all age groups but seemed to peak in the age group 36 to 50 years, which incidentally has a low rate of severe disease. This has been termed the post-acute COVID-19 syndrome or long COVID, and it's thought to occur in 10 to 30% of non-hospitalized patients and in 50 to 70% of hospitalized patients. Symptoms of long COVID may resolve within 6 months, but in a sizable fraction of these affected, symptoms seem to become chronic and overlap with the chronic fatigue syndrome, also known as myalgic encephalomyelitis. So, what are some of the symptoms of long COVID? Common neurological symptoms include anxiety, depression, lack of concentration, memory loss, and what is called brain fog. In some, there is persistent loss of smell and taste and disrupted sleep patterns. One characteristic manifestation is the postural orthostatic tachycardia syndrome, thought to be a result of dysautonomia. Fatigue and dyspnea are also hallmarks of long COVID, particularly after exercise or effort. Thromboembolic phenomena that may cause strokes or heart attacks or pulmonary embolism weeks or months after the acute infection have also been described. Several other manifestations involving other organs are also listed on the slide. So why do some people develop long COVID and others don't? We don't seem to have the full story yet, but there have been several proposed mechanisms, with immune dysregulation being at the core of these hypothesized mechanisms, perhaps with a component of genetic predisposition. Other proposed mechanisms include disruption of the microbiome, microvascular damage, persistent viral reservoirs with possible expression of different immune modulating viral proteins, and endothelial dysfunction. So, how can all this be prevented? In the early phase of the pandemic, we did not have any proven tools to mitigate the damage of SARS-CoV-2 infection. All we had were non-pharmaceutical interventions which were used to disrupt the transmission in the community and prevent the flood of patients to hospitals and healthcare centers, as we were dealing with a largely susceptible population lacking immunity against this virus. These non-pharmaceutical interventions included wearing masks, social distancing, hand washing, avoiding crowds, lockdowns, and other measures to interrupt the transmission. Where implemented, these measures were quite successful in decreasing not only the number of COVID-19 cases, but also other respiratory viruses such as influenza and RSV, which are similarly transmitted. The hope at the time was to develop a vaccine to allow herd immunity to develop gradually and minimize the rapid spread of the virus in the population. The breakthrough came in record time. Several vaccines using different approaches or platforms were developed, including the mRNA vaccines, the adenovirus carrier vaccines, the protein vaccines, all of which use the spike protein as the only antigen. Other approaches previously used with other viruses include the killed vaccines and the empty capsid vaccines. The mRNA vaccines were by far the most successful, being most immunogenic, the most effective, with a high safety profile, leading to the prevention of moderate to severe COVID-19. The technology of mRNA vaccines had been in development for about 30 years prior to its use in the COVID-19 pandemic. It relies on the delivery of modified mRNA that allows it to be stable enough to be delivered inside a lipid nanoparticle to the cell, where the cell will translate this mRNA into a protein. In this case, the spike protein is recognized as a foreign antigen by the immune system, and specific adaptive immunity is induced, allowing specific antibodies to be produced and specific cytotoxic and memory immune cells to develop. The dramatic success of the mRNA technology has opened the door for the development of a multitude of vaccines based on this technology against other pathogens. So, among the coronaviruses, and there are many of them, few have adapted to humans and have become human coronaviruses, including 3 that cause severe acute respiratory syndrome. These RNA viruses are characterized by a large armamentarium of proteins that can weaken or delay the human host immune response and can continuously mutate to evade the developed immunity. These viruses are easily transmissible, airborne, aerosol, and contact, and can lead to a wide spectrum of presentations, from the very mild to the severe or fatal infections. COVID-19 is also characterized by several short and long-term complications that may last several months or years following infection. Several treatments are available that may help modify the illness, but the combination of immunity from previous infections and vaccination are protective, at least against severe disease manifestations. The expected learning outcomes for the final part of this lecture include the understanding of the basic structure of adenoviruses and how its different species favor different clinical presentations. Also, to appreciate the plethora of viral products capable of modulating the host response to infection. Also, to understand the transmission and prevention of adenoviruses and learn about the wide range of clinical presentations. Finally, to get acquainted with the available treatments and their indications. Now, the third family of viruses that we'll talk about are adenoviruses. I touched a lot on these adenoviruses in the previous lectures. They got their name from being isolated from the adenoid tissue in the oropharynx. They cause a lot of infections in children and adults. They are very common viruses. They cause infection in both immune competent and immune compromised individuals. Their study, perhaps more than any other virus, led to a lot of knowledge and information about how our immune system works, about how gene transcription works, about how gene splicing works, and a lot of other useful information. Currently, adenoviruses have an additional importance in that they are being used in gene therapy, where scaled down adenoviruses can be engineered to carry genes of importance that can be delivered to needy hosts. The adenovirus has early, intermediate, and late genes. It is classified into 7 species, A to G, and the different species may be associated with different clinical presentations. The favorite receptor for adenoviruses is the Coxsackie adenovirus receptor on the host cell. There are several very interesting genes in the adenovirus. We talked about several of them in the previous lecture, those that regulate apoptosis and the cell cycle and in the inflammatory response. Several additional genes are actually of interest in regulating the inflammatory response. I will talk about 2 of them, which are whose proteins form the RID complex, the receptor internalization and degradation complex. This complex is able to pull down receptors from the cell membrane and cause their degradations. And among these receptors that are pulled down are receptors that are important in apoptosis, such as the TNF receptor and the FAS receptor. These receptors have a cytosolic side death domain, which recruits an adapter protein that also has a death domain that in itself recruits a caspase that has a death effector domain. So this chain reaction leads to the apoptosis of the cell once the receptor is ligated. So RID comes in to pull down these receptors and causes their degradation by proteolysis. So the infected cell that is now expressing RID can no longer undergo an inflammatory response, can no longer undergo apoptosis. So this is quite important in buying time for adenovirus to before the cell lyses due to viral replication. Now, adenoviruses are distributed worldwide, but the different species predominance varies with the region, and this changes over time. So as the herd immunity improves, then you get a different adenovirus that takes over and so on and so forth. So the virus is stable for several weeks on fomites in dry conditions. So there is a lot of room for infection and contamination and spread in the community. Transmission can be by inhalation of aerosolized droplets from infected individuals, and that can be also a cause for direct inoculation of the conjunctiva. And because this virus can cause gastroenteritis and can be shed in feces, fecal oral route transmission is another source of transmission. Recreational water such as swimming pools can be a source of infection, particularly in summer months when swimming pools are crowded. Airflow filters and other environmental surfaces can be a source of contamination as well. The clinical presentation of adenoviral infection varies. It can cause a lot of clinical presentations, including tonsillitis, gastroenteritis, pneumonia, etc. Children get infected frequently. They get about 15% of their upper respiratory infections and 5% of their lower respiratory infections are caused by adenoviruses. Most of the time, these are limited. It can also cause a latent form of infection in lymphocytes, particularly in tonsillar and intestinal tissue, which may relapse when immunity weakens, such as in severely immune compromised transplanted individuals. Immunity usually is humoral and T-cell mediated in response to adenoviral infection. So tonsillitis is quite common, and it's usually purulent and follicular in nature, associated with high-grade fever, and may last for 3 to 7 days. Sometimes there are associated symptoms such as cough, bronchitis, gastroenteritis, and other manifestations as well. No specific treatment is. Conjunctivitis is also a common feature of adenoviral infections. It can last about 1 to 2 weeks. No specific treatment is needed. Sometimes it is associated with pharyngitis and fever. Severe pneumonia can be seen in immunocompetent hosts, not only in immune-compromised individuals, and can be quite severe and sometimes fatal. Gastroenteritis due to adenovirus is quite common. The types 40 and 41 are usually responsible. It is perhaps the second most important cause of viral diarrhea in young children. And the presentation is typical: fever, vomiting, abdominal pain, and diarrhea, and usually lasts about 1 to 2. Meningoencephalitis is a rare manifestation of adenovirus, but it does occur in both the immune-competent and the immune-compromised host. Usually it's self-limited when mild, but can be quite severe sometimes and even fatal. In transplant patients, as their immunity weakens, there is reactivation of adenoviral that is latent, and this can cause significant fever and deterioration. So now there are recommendations to screen and monitor transplanted individuals to monitor their adenoviral load and to treat them when necessary. So it's becoming an emerging problem. Usually treatment is reserved for immune-compromised patients. The treatment is not given to the usual outpatient cases that we see. There is an oral vaccine that is against types 4 and 7 that cause outbreaks in armies. This vaccine is only limited to the USA Army. It's not available commercially. But for bone marrow transplanted or hematopoietic stem cell transplanted individuals, when they get adenoviral reactivation, we treat them with cidofovir, which is the best studied among the available antivirals. It's usually given once weekly, and it has to be closely monitored when the viral response is determined by measuring the viral load. It is nephrotoxic, and we usually stop treatment once we control the viral load. Ribavirin and ganciclovir are much less effective and are not used. A promising drug is the brincidofovir, which is the oral equivalent of cidofovir, and it's less nephrotoxic, so this is currently undergoing development. So, adenovirus is a DNA virus that comes in many types, with certain types or species associated with specific clinical syndromes. It has multiple viral proteins that are capable of modulating the host response, especially apoptosis, the cell cycle, and the immune response. It is widely distributed and environmentally stable, making it easily transmissible by aerosol, fecal oral route, or contact. Accounts for a significant fraction of respiratory infections, especially in children, and can become latent to re-emerge in those with severe immunocompromising conditions, such as bone marrow transplantation. It can cause a wide variety of clinical presentations that are generally self-limited and requiring no treatment. However, in severely immune-compromised patients, treatment is available and effective, such as cidofovir.